Hello, everyone, and welcome back. I hope you had a great break. It's been 5 minutes, and we're going to go back to orthopedic surgery on page 341 on Master of the Boards USMLE Step 3. We are looking at neurovascular entries, and we have a table here in the bottom of the page. And the table summarizes injuries that involve the neurovascular complications. It says here there are two types: the primary injury and the oblique distal humerus and the posterior dislocation of the knee. Of course, there are multiple types of injuries that can happen, but I think those are the very famous ones or the really classic examples. So we're gonna take a look at those. The first one is the oblique distal humerus, and the neurovascular complication, of course, is the radial nerves as it goes as the spiraling on the shaft of the humerus. And what we're gonna see as a sign is unable to dorsiflex the wrist and or extend the wrist. It's kind of like a dropped wrist, and the function is going to be regained after reduction. So that's really important. What is the next step in management in a patient like that? Surgery is indicated if paralysis persists after the reduction. So we try to reduce the fracture. If things are okay, that's fine. If not, we should do surgery. And this if paralysis persists after the reduction. Okay, the second one is the posterior dislocation of the knee, and when that happens, we have a popliteal artery injuries. And what we're gonna see is the decreased distal pulses, of course. And what the next step is gonna be is the Doppler studies or arteriogram. What we do later on is prophylactic fasciotomy if the reduction is delayed here. Okay. So the posterior dislocation of the knee, and we should reduce that. If not, we can do a prophylactic fasciotomy if the reduction is delayed. Okay, and we're done with that, and we're going on to the next page. We tackle back pain, very important one. A very important topic here. We're gonna have talk about disc herniation, ankylosing spondylitis, metastatic malignancy, and so on. So in back pain here, on the disc herniation, we have a question right away. The question says a 45-year-old man with a history of back pain. So, and the back pain has been for several months. It presents with sudden onset severe back pain that came on when he was moving a television. He describes an electrical shock that shoots down his leg, which is worse than when he coughs or strains, and is partially relieved by flexing his legs. The pain has prevented him from ambulating. Straight leg raising gives excruciating pain. What is the next step in management? It says here either we do a CT of the spine, and the second is dexamethasone right away. The C is immediate surgery. D is ibuprofen and brief bed rest, and E, MRI for the spine. I think we should do an MRI here to take a look if he has herniated the disc or something like that, but I might be wrong. So let's see. Okay, well, it says here the answer is D, actually. Ibuprofen and brief bed rest. So it says here that this is the classic presentation of lumbodisc herniation. Of course, okay. And it occurs almost exclusively at the L4, L5, or L5S1. The peak age is 43 to 46. All right. Anti-inflammatories and brief period of bed rest is all that is needed at this stage. Okay, and immediate surgical compression is needed. I think decompression, not compression, is needed if the history suggests coda equina syndrome. We look for bowel and bladder continence, flaccid anal sphincter, and saddle anesthesia, of course. It says that MRI can confirm both disc herniation and coda equina, but we do not answer MRI in classic cases of disc herniation. Okay, so this is where I went wrong here. And the trial of anti-inflammatories is also the first step in management. So we do not do MRI right away, even if we suspect it, because if you suspect it or if we think it is disc herniation, we should start right away on ibuprofen and brief bed rest. Okay. we have here a basic science correlate. It says that a sluggish ankle jerk reflex is suggestive of pathology at S1, S2. A sluggish patellar reflex is suggestive of a pathology at L4, L5. Okay, so ankle, S1, S2, patellar, or the knee, that's L4, L5. Okay. So the second pathology here is ankylosing spondylitis. This presents in men in their 30s and early 40s, and is going to present with chronic back pain and morning stiffness. Morning stiffness is very important here. That improves with activity. Another important part. So morning stiffness improves with activity. The X-rays eventually, when we do it, it's going to show a bamboo spine. Okay, that's a buzzword, very famous. It says here that it's associated with the HLA-B27 antigen. If you did step 1, that's a very famous association. We screen for another things that are associated with that, which are uveitis and inflammatory bowel disease, because they are associated with the HLA-B27. So this is something to consider. And how we manage it: anti-inflammatory agents and physical therapy. That's kind of like rheumatoid arthritis kind of management here, and it's very similar to rheumatoid arthritis. It says here, as a side note, in case of ankylosing spondylitis, we do not answer HLA-B27 antigen testing in first-degree relatives. We do not do that. The risk of developing ankylosing spondylitis based on the HLA-B27 positivity is very low and is not indicated for screening. So it's not a screening test. We do not screen for it. And we do not answer HLA-B27 testing in first-degree relatives. Okay, now we're done with the ankylosing spondylitis. Let's tackle metastatic malignancy. I think the bone is one of the most common sites of any metastatic malignancies, and it should be suspected in a number of cases. We said here that it says here that we should suspect the malignancy or metastatic malignancy in an elderly patient. That's first, and a progressive and constant back pain that is worse at night and unrelieved by rest. There's going to be a history of course of weight loss as well, and we do an X-ray in that case, and that's going to show a lytic lesion. We also look for hypercalcemia and or elevated alkaline phosphatase. Those are the two things that we can do, or a blastic lesion. So either a lytic or a blastic lesion, a lytic or a blastic lesion. We also always include a workup for the most likely malignancy based on the history and type of bone lesion here. So what we're going to perform in types of imaging here, we order a plain radiograph, so an X-ray. This is especially important if we suspect multiple myeloma. Second, we can do a bone scan, and this is most sensitive in early disease. And finally, MRI shows the greatest amount of detail and is the diagnostic test of choice if there are any neurological symptoms here. Then this is to rule out cord decompression. So if we have a patient we are suspecting that he could have either cord compression or it could be just metastatic malignancy in general, an MRI would serve both. So it can say that this is metastatic malignancy and it's doing some cord compression. So if we have some neurological symptoms, do an MRI. Okay, great. We have a side note here about the lytic and the blastic lesions. If we have a lytic lesion, like we said before, or metastatic lesion, we should suspect that it could be either lung, renal, breast, thyroid, or multiple myeloma. So again, let's do it in reverse here. That would help sometimes. So multiple myeloma, thyroid, breast, renal, and lung. All right, so the lung and breast, they are together, and the thyroid above them, and below them are the renal and multiple myeloma. This is kind of like an anatomic view of things, just to remember it. This is the lytic lesion. We should remember that. And the blastic lesion, however, it's going to be either prostate cancer or the breast cancer. So this, we can remember this as it's female or male type. It's going to be prostate for male and breast for female type of cancer. cancer. Of course, males can get breast cancer, but you know what I mean. Okay. So blastic is going to be breast and prostate, and lytic is going to be lung, renal, breast, thyroid, and multiple myeloma. Another side note here that says that bone scans will not be helpful in a purely lytic lesion, let's say for a multiple myeloma. Instead, we should order a plain radiograph or an MRI. So multiple myeloma or any lytic lesion for that matter, or a purely lytic lesion, it's not going to benefit from a bone scan that much. We should do the plain radiographs. Okay. We have in the next page here a basic science correlate that we should read. It says that lytic lesions can be caused by multiple myeloma and kidney and thyroid metastasis, while blastic lesions are caused by metastatic prostate cancer. I think this is well, just a repetition of what we said before when it came to blastic or versus lytic metastatic cancer to the bone. Okay, now we're done with the metastatic malignancy and how to approach it. And finally, we have the last part in the orthopedic surgery here, and this is foot pain. What will happen if we have foot pain? In foot pain here, we have two things to suspect. The first is plantar fasciitis, and this is commonly presented in older patients who are overweight and who have sharp heel pain every time their foot strikes the ground. You can see it with somebody who's training for a marathon as well. It says that the pain is worse in the morning. When we do an x-ray, it can show some bony spur matching the location of the pain, and there is an exquisite tenderness to palpation of the spur itself. However, surgical resection of the bony spur is not really indicated in that part, so x-ray makes no difference. So I'm not sure really what he's trying to say here. Should we do an x-ray or should we not? I think we should not do an x-ray. I think this is at least this is my information. If you know something different, please let me know in the comments below. But plantar fasciitis, it's going to be suspected based on the clinical history here. Give symptomatic treatment, that's our treatment, and the resolution occurs spontaneously in 12 to 18 months. And I think along with the symptomatic treatment, it should be rest. On a side note, it says that the pain in plantar fasciitis, it feels like a tack in the bottom of the foot, and it resolves quickly after walking. Okay. The last part here is Morton neuroma. Morton neuroma is an inflammation of the common digital nerve at the third interspace. This is going to be between the third and fourth toes, and it's going to be caused by wearing pointy-toed shoes. It says here shoes, which is really bad, but it's a mistake. It's pointy-toed shoes. The neuroma is palpable, and there is very tender spot there. So again, Morton neuroma is an inflammation of the common digital nerve at the third interspace. And we're going to see it as a palpable mass here, and it's very tender. What we're going to do for management, we're going to do analgesia and appropriate footwear. If this does not work, we follow a surgical excision. Okay? All right. So that's been it, actually, when it came to the orthopedic surgery, and we're done with it. That's awesome. Now we have to go into urology, and we still have 12 minutes or 11 minutes to the 25-minute sessions that we always do. So let's try to finish urology in that. Okay, so we have here a question as the first thing in urology, and talking about urology emergencies. It says here that a 24-year-old man presents in the emergency room with a very severe pain. His temperature on presentation is 102.3 Fahrenheit. Side note here, on the test, I think they do Celsius. They don't really put Fahrenheit. If somebody did the test and knows, please let me know in the comments below. But I think they do do not do Fahrenheit, they do Celsius. Anyways, his tests appear swollen and are tender to palpation. His testes, appear swollen and are tender to palpation. Urine analysis reveals 50 white blood cells, 0 red blood cells. Which of the following is the next step in management? Well, the first is antibiotics, and B, it's going to be culture and sensitivity, inguinal lymph node biopsy, testicular ultrasound, and prostate biopsy. Well, I think prostate biopsy, testicular ultrasound, that's going to be way off, and the inguinal lymph node biopsy, that's really that's too much. So we either do antibiotics or culture and sensitivity, because in that case we should be suspecting an inflammation or of the orchid or ocritis or epididymitis or something like that. So I'm gonna go with antibiotics as a general rule when it came to any inflammation or any infection, and then later on we can do culture and sensitivity. So what's gonna be? Okay, the answer is A, so it's antibiotics. Let's hope that my explanation is right. It says that the most likely diagnosis is orchitis and epididymitis. So, okay, that's awesome. So starting antibiotics is the best next step in management. All right, very good. Okay. So that was the first one here. So the second is testicular torsion. Testicular torsion classically presents as severe, sudden onset testicular pain without fever or pyuria. So torsion is severe, sudden onset testicular pain without fever or pyuria. The testis is swollen, exquisitely tender. They are high riding and with a horizontal lie. What we're going to diagnose with is an ultrasound on the testis, but we do not wait for the results. Do not wait for results to do surgery. We treat it immediately with surgical intervention with bilateral orchiopexy. Sorry. Bilateral orchiopexy. I'm really sorry, I couldn't really pronounce it well. Okay, so that's testicular torsion. It's an emergency. Do it right away. We diagnose with ultrasound, but do not wait for it. And it presents with severe sudden onset testicular pain without fever or pyuria. Okay, a basic science correlate is that the sensory and motor components of the cremastic reflex are at L1 and L2. Their absence is suggestive of testicular torsion. So if you do a cremastic reflex and it doesn't work, that means there might be a testicular torsion. Okay. The next pathology is acute epididymitis. The patient here is going to present with acute scrotal pain, sometimes referred to the abdomen as well, and it's going to be associated with fever and urinary symptoms. To diagnose that patient, we get a urine analysis and a urine culture, and we obtain a culture of the discharge if we actually find any. In terms of treatment, for males who are less than 35 years, we treat for gonorrhea and chlamydia with ceftriaxone and doxycycline. And we have older males we treat as a urinary tract infection for the E. coli, for example, and we give levofloxacin. That's actually really interesting. I didn't know that that's how we look at people, but. If it's a male who is less than 35, we treat for gonorrhea and chlamydia with ceftriaxone and doxycycline. So we suspect gonorrhea. In older males, we suspect that it's an E. coli, and we do levofloxacin. Okay, as a basic science correlate, it says that serotypes D to K of chlamydia trachomatis, which is an obligate intracellular. They are responsible for urethritis and other STD-related sequels. Oh, okay. The next part here has a question. I like questions. They are challenging and they make you think, so that's really good. It says here that a 72-year-old man is being observed. He has a urethral stone, and that is expected to pass spontaneously. He develops chills and a temperature of 102 Fahrenheit, flank pain, and elevated creatinine. Which of the following is the next step in management? Do we prescribe oral antibiotics? Do we prescribe loop diuretic? Do we perform lithotripsy? Do we place a Foley catheter, or finally, do we place a percutaneous stent? So let's take a look at that. He has a stone in the ureter, and it's expected to pass spontaneously, but he develops chills and temperature that is high, flank pain, and elevated creatinine. What we do? I think we should do C to perform the lithotripsy. We have obstruction here, and we need to do something that would remove the obstruction. But says here the answer is E, actually. So I was right about relieving the obstruction here, but it says that placing a percutaneous stent, that's what's gonna relieve the obstruction. Oh, okay. All right. So, okay. So we do not really move this stone. We just do a percutaneous stent to relieve the obstruction. Okay. Well, speaking of obstruction, let's talk about urologic obstructions. It says the combination of obstruction and infection of the urinary tract is a urologic emergency. It can lead to obstruction of the kidney in a few hours and potentially to death from sepsis here. So that's an emergency. What we do is treat the urologic obstruction in the following ways. First, we do immediate decompression of the urinary tract above the obstruction. The second, we do IV antibiotics. They are given to treat the infection. And finally, a ureteral stent or percutaneous nephrostomy is the most important intervention. They defer more elaborate instrumentation for a later and safer date. Okay. So really easy. Just decompress the urinary tract above the obstruction. IV antibiotics and ureteral stent or percutaneous nephrostomy is the most important intervention here. Okay. So now we're done with the urologic obstruction, or in general urologic emergencies, and let's talk about the congenital urologic diseases, and that's the final part in the urology. It says here that the following points are the urologic diseases that possibly require surgery when it comes to congenital urologic diseases. The first one, and the most common reason for a newborn boy not to urinate during the first day of life is posterior urethral valves. If we have a posterior urethral valve, what we do is we catheterize and we see to empty bladder. The second, we diagnose with voiding cystourethrogram. So we catheterize to empty the bladder, and we diagnose with a voiding cystourethrogram. The second one is hypospadias here, and it just means that urethral opening on the ventral side of the penis. And this is easily seen on a routine newborn physical exam. We never really perform circumcision on this child. The prepuce will be needed for the plastic reconstruction for that patient. So we should defer from doing that, and yeah, that's it. As a reminder here, we talked about the posterior urethral valve, how we catheterize to empty the bladder and diagnose by voiding cystourethrogram, and the second disease is hypospadias, and we can discover right away with the physical exam. And the thing that we do is we never perform the circumcision as we need for the plastic reconstruction. The third pathology, it's going to be a child who has hematuria from trivial trauma as an undiagnosed congenital anomaly, until proven otherwise. Okay, I just need to investigate that statement for a little bit. So if we have a child who has hematuria from trivial trauma, has an undiagnosed congenital anomaly until proven otherwise. Yeah, okay, well, sure. I mean, that doesn't really add much to question answering here, but okay. Well, anyways, another point is that a child with a urinary tract infection has an undiagnosed congenital anomaly until proven otherwise. Again, example, a vesico-ureterial reflux. Okay, what we do here is order a voiding cystogram to look for a reflux. If we find reflux, we give long-term antibiotics until the child grows out of the problem. All right, okay. The next point, it says that we suspect low implantation of a ureter in girls who void appropriately, but are also found to be constantly wet from urinating into the vagina. Okay, so a low implantation of the ureter in girls who void appropriately but are found to be constantly wet from urinating into the vagina. Okay. The last one is ureter pelvic junction obstruction. This is only symptomatic when diuresis occurs. UPJ presents classically in a teenager who drinks large volumes of beer and develops colicky flank pain. So this is the UVP and obstruction, and this is only symptomatic when diuresis occurs. Okay, I don't really like that last part. I think there is a sufficient lack of information here, and it's just like really basic information. It doesn't add much to answering questions, but I don't know. When we go to your USMLE world and start answering questions, probably that's going to be fixed where we can learn a little bit more, and maybe just reading the Kaplan book, like I said before, might help as well. So yeah. All right. Okay. So now we're done with the urology, and I'm really happy so far. We still have just vascular surgery and the patient safety. That's a small part here, and we can do it in one session in the next one. All right. Stay safe, study well, and see you in the next video. All right. Bye.